Good morning to everyone and welcome to today's session. It's a wonderful morning today, and we are all having one common dream to finish the revision of ophthalmology, which we started last Sunday. So, Padmanabha, Devabhrata, Sunny Sandeep, Rituraj, Ved Sharma, and many more who are all online. As always, when we start the session, we start with the quiz. Can you guys punch whether the voice is loud and clear for everybody? Can you please punch whether the voice is loud and clear? So let's start with a quiz. Keep punching your answers. Very nice to see 32 online students. Sorry, I got little late. By the time I was obsessively completing preparation for today's class. It was early morning 4 a.m. So I kept the alarm that I shall get up at 9 o'clock, but I could not accumulate myself. So by the time I got up, it was 10:30 a.m. Then I said, okay, let me postpone it to 11 o'clock. So thank you very much once more for joining the session. So doctor, let us start. It is the quiz time. So first I will give you around 35 questions for you to solve as a quiz. Every slide is moving at around 10 seconds. Yes. So let's start. Yes. Yes, doctor. It is the quiz time. You need to punch the answers, and after every 35-40 questions, you play the quiz. Guess what is your answer, and then we will have a discussion in our regular tradition. So by the time it is evening 6 p.m., we should get that feeling that yes, we made it. Most of the high yield topics in ophthalmology become covered. So the day is very long, doctor. Let us make the great beginning. I'll be vanishing out of the screen in order to give you an opportunity to punch your answers. 1 minute. I think there is an issue with. Yeah, finish the PPT show, doctor. The quiz, please punch. Yes, continuing our discussion of last week on the summary of the most favorite questions. These are all the questions asked in the last 15 years from the FMG question bank, but we need to remember that the NAT board is the one which conducts everything. So that is the reason All India, DNB, NEETPG, FMG, all these question banks, it's worthwhile to do a quick revision and let's make the continuity. Candle wax drippings on the fundus. Where do we see? We see in the case of the sarcoidosis, which is called the uveiparotid fever. You can see there is a periphlebitis about around the vessels, and that lead to the typical, just like the candle is dripping, similar to that, you get the candle wax drippings. Now, what is Marcus gun sign? Keep punching your answer, doctor. Prithviraj, Uday, and many more who are all online. So, Marcus gun sign, where do we see? We see it in the case of optic neuritis actually. Answer is not B. It is optic neuritis. We see Marcus gun sign. The correct answer is A. So even in case of the anterior ischemic optic neuropathy also, once there is a damage to the myelin sheath around the optic nerve, then that lead to what is called relative afferent pupillary defect, which is called the Marcus gun pupil, is what you need to remember. अच्छा भैया, मार्कस गन के बारे में हम एक क्विक पॉइंट डिस्कस करेंगे. आप सबको मालूम है there is a retina. From the retina, the optic nerve starts. It become optic chiasma. Then the optic chiasma is the one which is decussating and carrying the fibers. Excuse me. Carrying the fibers. So when you throw the light, what will happen? The light will travel along the optic nerve and it reaches the midbrain. In the midbrain, you have something called pretectal nucleus. From the pretectal nucleus, it will go to both the sides, Edinger-Westphal nucleus, Edinger-Westphal, both the sides. From the Edinger-Westphal, it will be going to ciliary ganglion, and through the ciliary ganglion, the fibers will go to the sphincter pupillae, and that lead to pupillary constriction. Both the sides pupillary constriction. So what is afferent in this entire pathway? It is the optic nerve. Optic nerve is considered to be the afferent in this entire pathway. So if optic neuritis हो गया तो क्या होता? When the light is thrown, it cannot be carried through the optic nerve. That is the reason there will be a absent direct pupillary reflex. The direct pupillary reflex is absent, right? Now, same time, unless the other side Edinger-Westphal gets a notification from the pretectal nucleus, the other side also won't react. So even there is a absent indirect pupillary reflex. Direct भी नहीं होता, indirect भी नहीं होता. But if you change the light to the other side, you will use a light and then put it on the other eye, then that eye will constrict, and even this eye also will constrict due to the consensual light reflex. This is how you can demonstrate that the absence of the light reflex in this right eye is because of the optic nerve में afferent में damage है. इसको कहते हैं Marcus gun pupil, which is an indication of relative afferent pupillary defect, is what you need to remember. So this is how you are throwing the light. I'll change the pen color. You are throwing the light. When you throw the light, normally this constricts and the other eye also constrict. But suppose if this eye is having a afferent pupillary defect, then this eye doesn't constrict and even the other eye doesn't constrict. So this is called relative afferent pupillary defect, or Marcus gun pupil is what you need to remember. So where do you see salt and pepper fundus? Keep punching your answer, doctor. Typically, this is seen in the case of the congenital rubella. So this is a classical fundus of a patient who is having salt and pepper fundus. कल के एग्जाम में examiner can give this as a image based MCQ. That's the reason you need to remember. भैया ये रेड दिख रहे हैं ना जी, ये है पेपर, right? So salt and pepper appearance. Where do we see rod spots? We see in case of infective endocarditis, this kind of infarcted multiple rod spots. You can also see there is a hemorrhage into the retina. Intraretinal hemorrhage also can be seen. So that is how in infective endocarditis we see the presence of rod spots. Where do we see retinal astrocytoma? Is a very interesting question. Can you please punch the answers? Mention the question number and punch the answers, so that this is like a revision session. A revision session is like bhajan. बोलो भगवान कृष्ण की जय, बोलो भगवान राम की जय. So हम सब भजन कर रहे हैं. Revision is almost like bhajan only. So that is the reason keep punching your answers also, मेरे प्यारे भक्तजनों. So retinal astrocytoma, where do we see? Very good. अभिषेक भजन कर रहा है. Retinal astrocytoma is in not all of the above. Abhishek. It is tuberous sclerosis. अच्छा, tuberous sclerosis के बारे में कुछ 5 पंक्ति बात करेंगे. Tuberous sclerosis is a phacomatous neurocutaneous disorder. Multiple benign tumors of embryonic ectodermal origin. What are ectodermal originated tissues, doctor? Skin, eyes, nervous system. And there is a triad of clinical features in tuberous sclerosis. Seizures, mental retardation, adenoma sebaceum. Of all this, adenoma sebaceum is found in about 3/4 of patients. So you know what is the triad of clinical features of tuberous sclerosis. You find subependymal giant cell astrocytomas. Between 8 to 18 years, they tend to be very large. They tend to have a very strong growth, intense enhancement of the white matter, and typically you will also find retinal phacomas. And there can be cerebellar atrophy, cerebral aneurysms, Chiari malformations. Microcephaly can be associated with tuberous sclerosis, arachnoid cysts. These are all the associations. So what are the diagnostic criteria of tuberous sclerosis? I'm so happy. 120 online students across the country. Excellent. Facial angiofibromas, periungual fibromas, hypomelanotic macules, shagreen patch, and retinal nodular hematomas. They are all major features identified clinically. There are tubers, multiple tubers in the cortex, subependymal nodules, subependymal astrocytomas, और दिल के अंदर कार्डियक रैप्डोमायोमास, lymphangiomyomatosis, और किडनी के अंदर you have angiomyolipomas, you have renal angiomyolipomas in case of tuberous sclerosis. So you can see these cutaneous lesions, doctor. Cutaneous lesions. What do you call these cutaneous lesions? They are typically adenoma sebaceum. Then in the eye, आंख के अंदर क्या होता है? You will find retinal. You find the retinal nodular hematomas. You can see how the hematoma is identified on the ultrasound of the eye, and subependymal astrocytomas. These are all the classical features. So now, what is the most common cause of the visual loss in HIV, doctor? It is the CMV retinitis, the most common cause. What do you find in case of when you do the fundus examination? Necrotizing retinitis is a classical feature of CMV retinitis. In the early stages, there are cotton wool spots, and the disease typically progresses along the retinal blood vessels. And don't forget, the most common ocular infection in the HIV positive patients, don't tell toxoplasma, only tell CMV. That is going to be your answer. And in those days when highly active antiretroviral therapy was not as prevalent as today, it used to be very prevalent, CMV retinitis. CMV is a double-stranded DNA virus, is what you need to remember. Now, let us see, yeah. Yes. I actually got some interesting video for you, doctor. That depicts the, yeah, let us review this video. Now, this is one classical case of the CMV. it will be more interesting. So now doctor, what are the features of hypercholesterolemia is my question to all of you. So you should remember lipemia retinalis, tendon xanthoma, Hollenhurst fundus picture, they're all invariably seen in hypercholesterolemia. Arcus senilis जो होता है, this may or may not be associated with hypercholesterolemia. That is what examiner is interested to know. So doctor, what you are seeing here is typically a lesion of arcus senilis. So let's look into arcus senilis. So this is the classical lesion of a arcus senilis. This lesion typically may or may not be associated with the hypercholesterolemia. So now you know how to recognize arcus senilis classically in this given patient. Now doctor, yes. So there is an annular lipid infiltration of the corneal periphery, and it may or may not be associated with hyperlipidemia is what you should remember. Now this is called lipemia retinalis, but this is invariably associated with hyperlipidemia, the lipemia retinalis in this 14-year-old. So lipemia retinalis में अगर आप उनका blood sample देखें तो it will be milky white in nature is what you should remember. So there are eruptive xanthomas which are also the feature of this hyperlipidemic patient. Eruptive xanthomas is what you should remember. Then tendon xanthomas, whenever a patient has an elevated LDL-C, LDL cholesterol, but a normal triglyceride, such a patient develops tendon xanthomas and tuberous xanthomas. This can be a image spotter in the tomorrow's exam. Now, a beta lipoproteinemia, इसका दूसरा नाम है, जरा रशियन भी सीखना पड़ता है, Besson-Cornevie syndrome, where you find presence of acanthocytes, where the RBCs have this kind of spiny projections, right, is called acanthocytes. This is called Tangian's disease, one more hyperlipidemia, where on the tonsils you are able to find the lipid deposits. They have a very low level of the HDL cholesterol is what you should remember. Now, photoretinitis is caused by what? It is caused by solar eclipse. Photoretinitis का दूसरा नाम है eclipse blindness, solar retinitis, photoretinitis, solar retinopathy, ये सब चीजें एक ही होता है, solar retinitis. It is due to direct or indirect sun viewing. It is also called eclipse retinopathy. How do you make a diagnosis of CMV retinitis? It is basically fundoscopy which will help you. Retinopathy of prematurity. क्यों होता है? It is the hypoxia that lead to retinopathy of prematurity. I mean, typically when it is a disease of retinal vasculature of immature retina in a premature neonate, where there is a interruption of the normal vascularization, and that lead to vasoobliteration, cicatrization, etc., etc. It is also called third epidemic. Favorite question of the examiner. Retinopathy of prematurity को कहते हैं third epidemic. Please remember. When does retinal vascularization begin, doctor? 16 weeks. In the phase 1, there is a vasculogenesis in the posterior pole, 21 to 22 weeks. Then the angiogenesis will progress towards oris aerata. The nasal ora get vascularized at 37th week, and temporal aura by 38th week, and choroidal vascularization is completed by 21 weeks. Whenever there is a hypoxic state in the utero, then when the PaO2 is very low, रेटिना को एक प्रत्येक स्वभाव होता है. It will produce vascular endothelial growth factor. So it is the one which lead to development of the prematurity, retinopathy of prematurity. Now, one of the favorite questions asked by the examiner is, भैया ये hypoxia की वजह से होता है या hyperoxia की वजह से होता है? So please remember, it is the relative hyperoxia which is the culprit leading to the development of retinopathy of prematurity is what you have to basically remember. So, whenever there is a premature birth, from birth to 32 weeks, there is a vasocessation. After 32 weeks, there is a relative hypoxia that leads to vasoproliferation. But the initial event is relative hyperoxia, which is the predisposing factors. So, what are the risk factors? 3 important risk factors which you need to remember. Birth weight, gestational age, and the number of days you have administered the oxygen. The parent is asking you, Sarji, कुछ special risk factors है क्या मेरे baby को ROP होने के लिए? Definitely. Multiple births, blood transfusions, IUGR, respiratory distress syndrome, then multiple apneic episodes, sepsis, intraventricular hemorrhage, vitamin E, which is antioxidant, deficiency of that, anything can be the risk factor. Sometimes, देखो भैया, ophthalmology examiner 10 questions आता है. So ophthalmology examiner will be waiting. It's like Oscar awards. What kind of question shall I put in this time NEETPG exam or FMG exam? So sometimes they will ask very specialist level का questions भी आते हैं. But we should be slightly prepared for that. So ये तो जरा specialist वाला question है. Stage 0 means immature vascularization. Line of demarcation is stage 1. A ridge with an elevated tissue is stage 2. Extraretinal fibrovascular proliferation, neovascularization is stage 3. Partial retinal detachment is stage 4. With the macula spread is 4A. Macula involved is 4B. Total retinal detachment is stage 5. So ultimately ROP will lead to vascularization, cicatrization of the pre-retinal tissues, and everything will pull the retina, and that leads to the development of the retinal detachment is what you need to basically remember. भैया इसको जरा यहाँ भी देखें तो conviction आना है डॉक्टर about a particular topic. Somehow you have to generate interest, conviction, think that you are the top ophthalmologist in the entire city, and then वो euphoric state में रीडिंग रूम में बैठ के पढ़ाई करना है, राइट? सो दिस इज इमेच्योर वैस्कुलराइजेशन, स्टेज 0. स्टेज 1 का मतलब है देयर इज ए लाइन ऑफ डिमार्केशन, दिखाई दे रही है ना? हाँ. एंड देयर इज एन एबनॉर्मल ब्रांचिंग ऑफ आर्केडिंग वेसल्स पोस्टीरियरली. स्टेज 2 में तो रिज हो गया, रिज व्हाइट टू पिंक. देन stage 3 is extraretinal neovascularization शुरू हो गया. That becomes the stage 3. Good to see Abhijit Wakande, Draman Sharma and many more. D. Raman Sharma. Okay. 150 ऑनलाइन स्टूडेंट्स. हमारे सौभाग्य है, हम आपको पढ़ाई करने का मौका मिल गया हमको, राइट? सो January 5th घंटी बज गया NEETPG एग्जाम का. हम भी सोएंगे नहीं, हम भी आराम से बैठेंगे नहीं, हम आपके साथ पढ़ाई करेंगे, रोज पढ़ाई करेंगे, आपके हाथ पकड़ के आपको टॉपर बनाएंगे, राइट? सो प्लीज बिकम पार्ट ऑफ आवर व्हाट्सएप स्टडी ग्रुप. There are thousands of students who are part of our WhatsApp, and you get a morning to evening a mela, MCQ का मेला मिल जाएगा. और in order to become the part of the WhatsApp group, study group 9000868356, our helpline number. हमारे helpline number को call करके add yourself. And we also have 600 hours of video, 30,000 MCQs, 30,000 MCQs, and ये 3 lakhs होता है, 30,000 MCQs, and about 2 lakh PowerPoint slides जैसे आप देख रहे हैं, and online mock tests every week, and there is a discussion, full scale grand test का, and you get everything on the onlinembbs.com. Next 3 months के लिए take a subscription, call the helpline, and they will be more than happy to help you. So this is mild, moderate, severe type of a retinopathy of prematurity. Stage 4A means macula spared, and 4B means macula involved in the retinopathy of prematurity. अच्छा भैया? Yes. What type of retinal detachment do you get in retinopathy of prematurity? Exudative in the early stage, tractional later, finally rhegmatogenous. All 3 types of retinal detachments can very much happen, and this is the total retinal detachment. So this is another example of a retinal detachment, a total retinal detachment in the case of the retinopathy of prematurity. Now, one of the favorite question. Plus disease क्या होता है? Plus disease. Ritu is saying, sir, these classes are not there in the online MBBS. No, they get uploaded. After the session is over, we remove it from YouTube and upload it into the onlinembbs.com video library. And also there is a folder called 30,000 MCQs. हॉट MCQ डिस्कशन बोल के फोल्डर है onlinembbs.com में. रितु, प्लीज कॉल अवर हेल्पलाइन 9000868356 to activate that 30,000 MCQ discussions also, where we have got PGI, AIMS, everything, topic wise revised, subject wise, topic wise, questions are debated, discussed, and then all those videos are available. Now, plus का मतलब क्या होता है? Posterior venous dilatation, arterial tortuosity at least 2 quadrants, and it arises very rapidly, and there is a AV shunting in the ridge tissue, which lead to development of the plus disease is what you need to remember. There is also iris vessel engorgement, meiosis, vitreous haze, tunica vasculosa lentis. They are all the part of the plus disease is what you need to remember. Soumya Singh is saying, sir, please take pediatrics also. क्यों नहीं? हमको another 12 weeks का time है. आराम से every Saturday, Sunday, 1 day, 1 subject. 1 day, 1 subject scheme के अंदर हम पूरा revision करेंगे. So just be part of our academic communion. Soumya ji, please call our helpline in order to get a subscription to the onlinembbs.com video library. Now doctor, pre-plus disease क्या होता है? There are vascular abnormalities in the posterior pole more than the normal and less than the plus. इसको कहते हैं pre-plus. So how do you treat, doctor? Retinopathy of prematurity को how will you treat is an important question. Obviously, any hypoxic retina stimulates vascular endothelial growth factor leading to the development of neovascularization. इसलिए हम वो vascular tissue जो है उसको खत्म कर देना. उसके लिए retinal ablation is what you do. Cryo and laser, scleral buckling, vitrectomy, lens sparing or with lensectomy. You do the vitrectomy. There are all the ways. You need to basically remember that you treat the retinopathy of prematurity is what you need to remember. Now, doctor, let's look into one case of retinopathy of prematurity. Okay, let's go to 124. Yes. Now, how do you do the screening of the retina? With regard to the retinopathy of prematurity, the examiner's question is, um, what is accept about it? Prematurity, वो direct नहीं भैया, indirect ophthalmoscopy is used for screening at around 32 weeks, and earliest sign is dilatation of the veins. Please don't forget, favorite single liner of the examiner. It is seen with FiO2 more than 50%. That is called hyperoxia. Hyperoxia predisposes to the retinopathy of prematurity. कल्पेश पटेल जी हमको हुक्म दे रहा है, सर जी एनाटॉमी को रिवीजन करो. भैया हम इवनिंग क्लासेस 6 to 9 p.m. 3 weeks back only we have taken a complete revision of 700 MCQs topic wise in anatomy. All the anatomy lectures are all available. Kalpesh ji वो onlineMBBS.com वीडियो लाइब्रेरी में अवेलेबल हैं, आप आराम से रिवीजन कर सकते हैं. प्लीज बाय वन सब्सक्रिप्शन. प्लीज डू कॉल 9000-868-356 in order to get the topic wise review of anatomy, and all other videos are all available for you. Now, doctor, this is how you will be doing the monitor screening. So what is this? Indirect ophthalmoscopy is the one which is used in order to identify and do the screening of the retinopathy of prematurity. Now, the next topic is myopia, hypermetropia. The newborn cannot be able to prepare for the NEETPG exam. इतना मोटे मोटे बुक को ओपन करके पढ़ना बोले तो मुन्ना को दिक्कत हो जाएगा, क्योंकि मुन्ना हाइपरमेट्रोपिक है. कितना? +2 to +3 diopters is what you should remember. Accommodation is maximum in case of children. इसलिए चिल्ड्रन में एट्रोपिन ऑइंटमेंट का इस्तेमाल करता है. पावरफुल एट्रोपिन को इस्तेमाल करना पड़ेगा if you want to do pupillary dilatation. Convex lens is used in the case of the hypermetropia. अच्छा भैया, हाइपरमेट्रोपिया और मायोपिया के बीच में डिफरेंसेस क्या है? 5 पंक्तियों में आंसर करो. ऑब्जेक्ट फॉल्स बिहाइंड द रेटिना. बिहाइंड द रेटिना, राइट? सो रेटिना के पीछे क्या है? हाइपरमेट्रोपिया है. मायोपिया, image falls before the retina, in front of the retina, is what you need to remember. Now, the purpose of convex lens is basically to make पीछे लगे इमेज को फिर रेटिना पर लाने के लिए आप खींचेगा उसको. दैट इज हाइपरमेट्रोपिया में कॉन्वेक्स लेंस. Concave lens will push the retina which is falling. ये retina है, image retina के सामने आ गया, उसको फिर retina के ऊपर push करने के लिए आप concave, cave के अंदर push करना है ना, cave के अंदर. Retina is a cave, cave के अंदर push करना है क्योंकि cave के in front में image आ गया, right? So concave is myopia. Then if the correcting lens is itself moved forward, the image will move still forward and the effectivity of the lens become increased. Hypermetropia में reading lenses रहता ना डॉक्टर. So reading lenses जब आप आगे लेके गए तो it will become more effective. And in the case of the myopia, if the correcting lens itself is moved forward, the image will move still forward and the effectivity become reduced. In case of the myopia, one of the favorite questions of examiner. So a weaker lens is required to project the image onto the retina in hypermetropia, whereas a stronger lens is required to project the image onto the retina in case of myopia, is what you need to basically remember. Now, in the case of the myopia, yeah, I think now the streaming should be all right for most of you. Can you please punch whether the streaming is okay? Is the streaming is okay, doctor? Yeah, I went a bit out of the stream. Okay. Now, what do you see in case of the myopia? The nasal margin is not well defined. The margins at the superior and inferior poles. Is the broadcast fine for all of you? Good. Inferior poles and in small optic discs, they are obscured due to crowding of the nerve fiber bundles. Then there is a choroidal crescent. Choroidal crescent. A crescent जो होता है, you can be able to see it over here, the crescent, right? The crescent. Crescent is a gap in the retinal pigmentary epithelium revealing the underlying choroid because of the oblique insertion of the optic nerve. That lead to development of the choroidal crescent, scleral crescent. Both the crescents arise from the temporal aspect of the disc is what you have to remember. Now, what is the vertical diameter, doctor, normally of the optic disc? Now we are trying to do a bit of revision on the optic disc. 1.8 mm is vertical, 1.5 is horizontal diameter, depth is 1 mm and cup disc ratio varies between 0.1 to 0.9. And what is ISNT rule, doctor? Inferior nasoretinal rim is the broadest, followed by superior nasal temporal, superior nasal temporal. Inferior is the broadest, is what you have to basically remember. Physiological cupping, horizontally oval and deeper in nasal quadrant, इसको physiological cupping कहते हैं. The cup disc ratio generally is not more than 0.7 except in 0.2% of population. And a large disc means if it is more than 0.55, a small optic disc means less than 0.35. Jara measurements like a tailor, you should remember emphatically, doctor. Now, If you look at the retinal vessels, the veins lie temporal to arteries, and the veins lie temporal to arteries. Normally, arteries pulsate, veins do not. In the case of the retina, veins normally pulsate. Veins are the ones which normally pulsate, arteries do not pulsate. अगर arteries pulsate हो रहा है, इसका मतलब है there is a raised intraocular pressure is what you have to basically remember. So doctor, let us look into the interior of the retina. Interior of retina. So yes, interior of retina. एक बार आप इंटीरियर ऑफ रेटिना को देख लिए तो आप भूलेगा नहीं. इंटीरियर ऑफ रेटिना, हाँ, this is once more we are talking about the story of the retinopathy of prematurity only. You can see retinopathy of prematurity can be diagnosed by indirect copper wire appearance whenever there is any reflection of the light at the vessel center. There can be thickening of arterioles. So retina talks a lot about your general medicine, aging, arteriosclerosis and hypertension, changes in the AV crossings, and a very narrow thready arterioles whenever there is any tapetoretinal degeneration. So these are all the things that are seen in the retina. Now comes the favorite question of the examiner. Small optic disc कहाँ होता है? Hypermetropia, aphakia, tilted optic disc or optic disc hypoplasia. Mainly hypermetropia. Hypermetropia. Eye is small, disc is small. Large optic disc, you find it in high myopia. Optic disc coloboma. मॉर्निंग ग्लोरी फ्लावर के जैसे कभी कभी ऑप्टिक डिस्क दिखता है, इसको कहते हैं मॉर्निंग ग्लोरी एनोमली. मेगलोपैपिला, they are the feature things where large optic disc is found. But favorite question of the examiner, one point you need to remember, what is that? Myopia has big eyes and a big optic disc. This is what you should remember. अच्छा भैया, मॉर्निंग ग्लोरी ऑप्टिक डिस्क क्या होता है? इट इज दैट enlarged nearly circular optic disc containing a deep conical depression with the white or pink glial tissues in the base, which is called morning glory optic disc. It can lead to serous retinous detachment. That is the reason we need to remember. And the retinal vessels loop over the edge of this optic disc in a radial fashion. Just like आपको ये morning glory flower है, जैसे यहाँ radiation हो रहा है, वैसे ही यहाँ भी blood vessels radiates around that central optic disc, which is large optic disc, which is typically seen in the case of the morning glory anomaly, is what you should remember. This is neovascularization at disc. What are the causes? What lead to a lot of neovascularization at disc? Proliferative diabetic retinopathy, retinal vein occlusion, old retinal artery occlusion, ocular ischemia, radiation retinopathy, anything can lead to neovascularization of the disc. भैया disc hemorrhages क्यों होते हैं? What are the causes? Each of this is a favorite MCQ of the examiner in ophthalmology. Ophthalmology is a very easy subject. मगर एक मर्तबे आप व्हाइट वॉश करना पड़ता मेरे साथ करें तो it is a cakewalk. 10 out of 10 you can score in the NEETPG, right? Now, acute papilledema, papillitis, diabetic papillopathy, optic disc drusen, anything can lead to the development of disc hemorrhage is what you should remember. Retrobulbar neuritis, early stage में fundus normal रहता. What is a very famous saying? Patient cannot see, doctor cannot see. डॉक्टर को भी कुछ नहीं दिखाई देगा, पेशेंट को भी देखने में दिक्कत है. He can't see. That is retrobulbar neuritis. Patient can see, doctor can see. What is that condition? Papilledema. Papilledema में आप देख सकते हैं papilledema को. And patient does not have any visual obscuration because of papilledema. So patient can see, doctor can see. Papilledema, patient cannot see, doctor cannot see, is retrobulbar neuritis. Finally, doctor can see, but patient cannot see. वो होता है papillitis. जहां ऑप्टिक नर्व जाके रेटिना के अंदर इंसर्ट हो रहा है, वहां कुछ इन्फ्लेमेशन है तो उसको कहते हैं papillitis. Doctor can see, but patient cannot see. That is papillitis is what you should remember. Ultimately, retrobulbar neuritis will lead to optic atrophy. Then the doctor can see retrobulbar neuritis. Papillitis. Early stages में disc is moderately swollen. Later on, it lead to the optic atrophy. So that is papillitis. Then there can be a optic neuropathy. It can be retrobulbar, it can be ischemic papillopathy or arteritic papillopathy. Then this is Leber's hereditary optic neuropathy. A swollen hyperemic optic disc is the classical feature. Late stages may even Leber's hereditary optic neuropathy also, you find the presence of secondary optic atrophy is what you need to remember. Now, primary optic atrophy without any secondary cause, what do you find? A chalky white optic disc with a clearly defined margin. Chalky white optic disc. The disc is more pallor, more on the temporal side. There is an atrophied neuroretinal rim, loss of physiological cupping, flattening of the optic disc. But the point is what? What is the favorite question of the examiner? Bhaiya, primary optic atrophy or secondary optic atrophy के बीच में what is that subtle difference? No gliotic changes, no vascular changes, but there is optic atrophy. वो होता है primary. जब gliotic and vascular changes के साथ optic atrophy है, that is secondary optic atrophy. That is what you need to remember. Secondary optic atrophy में there is a grayish white swollen optic disc, poorly defined margin, but gliotic changes can be there, which is classical of secondary optic atrophy. Then consecutive optic atrophy. In this, you have a pale yellow waxy looking flat optic disc is what you find. It has got a well defined margins and very minimal gliotic changes. These are the bony spicules which you can see. That is retinitis pigmentosa में consecutive optic atrophy is what you should remember. Then जिन लोगों को ग्लूकोमा है, एडवांस्ड ग्लूकोमा है, in that they develop peripapillary atrophy. There is an alpha zone, there is a beta zone. Alpha zone, beta zone. So in the beta zone, you can see large choroidal vessels, and glaucomatous eyes may you find peripapillary optic atrophy is what you should remember. Then myopia is not just about lens and refractive error. Pathological myopia is an overall degeneration of the sclera, retina, vitreous and multiple tissues of the eye in that large eye, myopia, pathological myopia. So in this, the optic disc become distorted. There's a tilting of the optic disc towards temporal side. Retinal vessels appears dragged, and the nasal vessels, they curve around that elevated nasal sector of the optic disc. You can see the nasal vessels which are typically curved around the nasal disc, and there is a myopic crescent. These are all the features that you see in case of myopia is what you should remember. Hypermetropia में क्या होता है डॉक्टर? It will be a small pink optic disc, and the central retinal vessels, they all become crowded around that small optic disc, and in severe cases there will be horizontal folds in the choroid in the peripheral fundus is what you need to remember. Then glaucoma, what do you see? In glaucoma there is a focal atrophy and a concentric atrophy. And bioneting sign will be found in the glaucoma. Retinal vessels bend sharply at the edge of the optic disc, which is called bioneting sign. Then concentric hypertrophy, it begins temporally and progresses circumferentially with the temporal unfolding. That is what you see in concentric atrophy. Now you can see this is a large optic disc with a large physiological cupping, with a preserved healthy neuroretinal rim, widest at the inferior pole and narrowest at the temporal quadrant is what you are able to see. ISNT, I more than, S more than, N more than, T is the least. And this is a glaucomatous cupping where cup has extended all towards the margin of the disc and the neuroretinal rim has become narrowed is what you should remember. Now this is advanced glaucomatous cupping. This is a total cupping white disc with the loss of all neuroretinal tissue around it is advanced glaucoma, and there is a bending of the vessels at the margin of the disc. Bend hoke ja rahe hain, right? So that is advanced glaucoma. अच्छा, एक दो बातें पेपिल के बारे में बात करेंगे. A swollen optic disc, indistinct margin. Papilledema first कहाँ दिखता है? First in the nasal quadrant, then in the superior, then in the inferior, and typically when papilledema becomes severe, there will be concentric retinal folds. Retina के अंदर folds बन जाता है. ये folds को कहते हैं Patton's lines. What is the name given for it? Patton's lines is the name of these folds. And you also find folds inside the choroid when the papilledema become severe enough. So in the acute phase, whenever papilledema is there is a lot of accumulation of the fluid and exudates in the nasal aspect of macula, and that is called macular star is a feature in case of papilledema. Long standing cases में this virtually become like a champagne cork appearance कहते हैं इसको. क्या बोलते हैं? Champagne एक बार शैंपेन पिए तो शैंपेन कॉर्क मालूम पड़ेगा. Champagne cork appearance of the optic disc is typically seen in the case of the long-standing cases of papilledema, is what you need to remember. Finally, in the atrophic stage, you find secondary optic atrophy in papilledema. Now, optic disc drusen. In this, there is a small optic disc, the drusen hidden with the substance of the nerve head, optic nerve head. There is something called pseudo-papilledema. It looks like papilledema. Pseudo-papilledema is seen in optic disc drusen. The central retinal vessels will show anomalous branching. So these are all the features of optic disc drusen. Whereas in the case of the adults, the drusen can be single or multiple glistening semi-translucent, and it will have a yellowish pink appearance. It become enlarged, it can develop splinter hemorrhages overlying it. That is the optic disc drusen. Finally, you should know how a melanocytoma typically looks like in its appearance. It is eccentrically placed on the optic disc, extending over the disc margin. Melanoma is extremely common condition relatively. Now, astrocytic hematoma. अभी अभी हम देखा ना, वीडियो में देखा ना. So in tuberous sclerosis, there is a mulberry-like white reflective mass which can become calcified. That is astrocytic hematoma. Then coloboma. Coloboma is that enlarged optic disc, and the deepest part of the coloboma is located inferiorly. It is the glistening white tinged appearance, and there will be lot of blood vessels that cross the border of the coloboma, is what you have to remember. 1% of people you may find myelinated optic nerve fibers. They are not present in birth. They will be wide, highly reflective lesions with feathery margins. Myelinated nerve fibers. Then few congenital vascular anomalies, which you have to be very sure. This is called persistent hyaloid artery. It is bloodless, transparent, thread-like remnant. Bloodless, transparent, thread-like remnant. And anterior to the retinal artery, there can be a Mittendorf's dot because of its attachment to the posterior lens capsule. Mittendorf's dot and persistent hyaloid artery, you should remember. Then Bregmeister's papilla. Bregmeister's papilla. When there is a persistent hyperplastic primary vitreous, इसको बोलते हैं Bregmeister papilla, is what you need to remember, and it is present in nasally, and the physiological cup is reduced. It looks like a yellow-white protuberance coming out of the optic disc. Bregmeister's papilla, which is persistent hyperplastic primary vitreous, is what you should remember. Shanti, Shanti, Shanti. Now you understood what are all the things that can be shown, that can be seen inside the optic fundus, which is the favorite question of the examiner. Now, what will happen if you are excessively using accommodation, doctor? Excessive accommodation lead to pseudomyopia. So, the tone of the ciliary muscle become excessively increased, leading to pseudomyopia whenever you are having excessive accommodation. If you are not using the reading lenses and you are trying to read the NEETPG book, if you don't get seat up to 40, right? Then excessive accommodation will lead to pseudomyopia. There will be macropsia, asthenopia, meiosis, convergence, etc., etc. Now, different refractive power between two eyes. What do you like to call that as? Anisometropia. Most common type of hypermetropia, simple ही most common होता है. अच्छा, एक मर्तबे हम हाइपरमेट्रोपिया के बारे में बात करेंगे. Axial hypermetropia is most common, and axial length less than 24 millimeters lead to axial hypermetropia. एक गोल्डन नंबर होता है डॉक्टर, आपके 200 पेजेस नोटबुक के अंदर ये जाना पड़ेगा, right? Physiological hypermetropia will be around plus 2.5 to 3 diopters at birth. And pathological hypermetropia होता है orbital tumors, coloboma, microphthalmic conditions. And these are important points. Now, index hypermetropia. Any increased refractive index of the cornea or vitreous, typically in those who are having diabetes. Whenever they have a poor glucose control, there is a lot of sugar that will suck water into the lens. So increased refractive index lead to index hypermetropia. And any posterior displacement of the crystalline lens lead to positional hypermetropia, not anterior displacement. Posterior displacement will lead to positional hypermetropia. Then aphakia, अगर लेंस को निकाल दिए तो आप, that also lead to hypermetropia, like traumatic dislocation or a surgical removal of the lens. Aphakic lens is hypermetropic. Aphakic lens is hypermetropic, not myopic. That's what you should remember. A simple is the commonest form. Then pathological hypermetropia, congenitally because of the absence of the lens or acquired because of the cortical sclerosis in the old age. Positional because of the postural dislocation of the lens, or consecutive hypermetropia if there is a surgical overcorrection of the myopia or a wrong intraocular lens लगा दिए तो होगा hypermetropia. And any paralysis of the accommodation because of the third nerve palsy, internal ophthalmoplegia, that lead to development of functional hypermetropia. So doctor, typically there is a convergence that happens by accommodation. A convex lens क्यों इस्तेमाल करते हैं? Because it will increase the converging power. Natural accommodation is unable to increase the converging power, then convex lens लगाना पड़ता है. And the image formed in a hypermetropic eye is smaller than the emmetropic eye, and the rays diverge from the retina. And if converging power of the eye is increased by putting the convex lens, then the clear image is possible, is what you have to remember. So that is little story about hypermetropia, doctor. Definitely one question from refractive errors. NEETPG हो, FMG हो, एम्स हो, PGI हो, जिपमर हो, जरूर आने वाले टॉपिक्स है डॉक्टर. There are 953 topics like this. Topic wise आप 20-30 MCQs को लेके वो डिस्कशन रिवाइज करें तो most of the issues about that topic are resolved. 953 टॉपिक्स को रिवीजन करने के लिए आपको 600 आवर्स का टाइम लग जाएगा. और www.onlinembbs.com वीडियो लाइब्रेरी में हम आपके लिए गरम हॉट इडली के जैसे, डोसा के जैसे रेडी करके बिठाया. आप सब्सक्राइब करो onlinembbs.com वीडियो लाइब्रेरी को, 3 महीने का सब्सक्रिप्शन ले लो. उसमें आपको पूरा वीडियो लाइब्रेरी, 2 लाख पावर पॉइंट स्लाइड्स, एवरीथिंग मिल जाएगा और आराम से सेल्फ प्रिपरेशन कर सकते हैं आप कहीं भी बैठ के. फिर भी हम आपके साथ रहेंगे ताकि आपको रोज एक्टिवेशन मिल जाएगा. The whole job of a teacher is to create that enthusiasm inside you to get up, take up the books, go happily, confidently, joyfully to the reading room, do the revision. Next 90 days is going to decide what MD you are going to do, practice until you are 90-year-old. So that is the reason, enjoy this beautiful 90 days. Don't think about the outcome, don't think about the result, right? Don't think what happens if I don't get it, what happens if the questions I can't remember. Oh sir, chhod do doctor, they're all hallucinations. The most important thing you need to remember at this stage, doctor, please remember, हर एक के दिल में ख्वाब रहता है, हम पढ़ाई करेंगे, वो ख्वाब रहता है. Who is the biggest enemy of oneself? Oneself is the enemy of oneself, doctor. Uddharet atmanatmanam atmanam avasathe atmaina atmano bandhuhu atmaina ripuratmanaha. Ripu means enemy. We ourselves are the enemy of us. We kill our own opportunities to become something great. And I want to tell you, you should not do that. 90 days is a wonderful time. खेलते खेलते आप रिविजन कर सकते हैं, provided you are focused in what you are preparing, you are very clear on what you are reading. Don't run because वो मटेरियल पढ़ रहा है, ये मटेरियल पढ़ रहा है, वो इसके पास कोचिंग को गया, ये उसके पास कोचिंग को गया, वो सब छोड़ दो. आप क्या है, आपके अंतरात्मा को बोलना कि भैया मैं 90 डेज में तुझे महाज्ञानी बना के फोकस्ड वे 953 टॉपिक्स रिवीजन करके एग्जाम को जाऊंगा. आई टेक एवरी अपॉर्चुनिटी दैट 30,000 MCQs of last 15 years, PGI, AIMS, All India, NEETPG, JIPMER, DNB, FMGE, ये सब क्वेश्चन बैंक्स को मैं क्विकली रिवीजन करूंगा. And then I'll go to the exam. Nobody is going to stop you from becoming the topper, right? So, sudden increase in sugar in diabetics, what does it lead to? A lot of times, there is something called myopic shift. Once there is an increase in blood sugar level, hyperglycemia, increased osmotic pressure, increases the refractive index of the lens, and that is called myopic shift, is what you need to remember. These are all used for distant vision, except, all of you know what are the tests used for the visual acuity, right doctor? Visual acuity. Landolt C chart, Snellen chart, E chart, ये सब चीजों को इस्तेमाल करते हैं. Landolt rings, numbers, fingers, tumbling E, letters in Snellen, all of them are used. This is called Landolt C chart. ये भी विजुअल एक्टिविटी के लिए इस्तेमाल करते हैं. थंबलिंग ई चार्ट, इसको भी इस्तेमाल करते हैं. नाउ व्हिच कंपोनेंट ऑफ द आई हैज द हाईएस्ट रिफ्रैक्टिव इंडेक्स डॉक्टर? लेंस कॉर्टेक्स. फोस्टर फ्यूग स्पॉट्स, वी फाइंड इट इन केस ऑफ मायोपिया. सो इफ यू लुक एट द फंडस ऑफ मायोपिया, ऑप्टिक डिस्क इज लार्ज, पेल, टेम्पोरल एज में होता है मायोपिक क्रेसेंट, which is very characteristic. Then there is a peripapillary crescent encircling the disc, and there is a supertraction crescent present on the nasal side where the retina is pulled over the disc margin. So you can see temporal myopic crescent, macular degeneration, and tessellated fundus. इसको कहते हैं tessellated fundus is what you should remember. Right? So this is how you can see the presence of the crescent, is what you're able to see. And the degenerative changes in retina and choroid are very common in progressive myopia. There will be white atrophic patches in the macule, and there is a heaping of the pigment around them. And what you find? Dark red circular patch because of the subretinal neovascularization and choroidal hemorrhage present at macula. इसको कहते हैं Foster Fuchs spot, is what you have to basically remember. And myopics have a degeneration of the posterior pole of the eye. That is the reason there is a bulging of the sclera in the posterior aspect. भैया एक ग्लोब है, ये एंटीरियर है, ये पोस्टीरियर है. पोस्टीरियर में there is a bulging which typically happens in the sclera, which is called posterior staphyloma, is what you need to remember. And vitreous में भी changes होता है in case of pathological myopia. Liquefaction, vitreous opacities, posterior vitreous detachment, these are all the features of myopia. Myopia may visual fields undergo contraction, ring scotoma will develop, and there is a subnormal electroretinogram because of the chorioretinal atrophy in case of the myopia, is what you should remember. Myopia can predispose to retinal detachment, complicated cataract, vitreous hemorrhage, choroidal hemorrhage, and strabismus. Strabismus fixus convergence is a consequence of myopia, is what you have to remember. Now, that is the story of myopia. Refractive errors अभी आपको grip में आ गया ना concept. So जरा और एक मर्तबे रिविजन करना है, right? Now, what is the most common cause of bacterial corneal ulcer, Doctor? Staphylococcus. Staphylococcus का corneal ulcer, it will have a central oval plaque, distinct margins, mild edema of the remaining cornea, bullous keratopathy, atopic diseases. Such ISCO, staphylococcal infections are most common. Now, doctor, which drug stains the cornea? Thioridazine stains the cornea. Fatafat bolo, different types of drugs which are affecting the cornea, doctor, which are affecting the cornea. Vortex keratopathy, horror-like corneal epithelial deposits होता है vortex keratopathy में, and typically anti-malarials like chloroquine, hydroxychloroquine, they are the ones which lead to vortex keratopathy. Vortex keratopathy. Amiodarone, which is the one which is used in atrial fibrillation, lead to the development of verticillate keratopathy. Verticillate keratopathy is what you need to remember. Chloropromazine is the one which lead to anterior lens capsule deposits and retinopathy. Againosis, because of the deposition of the silver deposits, they typically happen into the Descemet's membrane. Then chyriasis, deposition of the gold in the rheumatoid arthritis patients. Corneal chyriasis is what you have to remember. Then amantadine, it leads to a diffuse white punctate opacities. Amantadine. Steroids, they lead to development of posterior subcapsular cataract, characteristic of steroid therapy. Chloropromazine, it leads to fine stellate yellowish brown granules on the anterior lens capsule, is a classical feature. Busulfan, used in CML, it can lead to lens opacities. Allopurinol, used in hyperuricemia, it also can lead to development of cataract. Rifabutin, used in the case of the TB, it can lead to acute anterior uveitis with hypopion. Then biphosphonates, used in the osteoporosis, they are also implicated to lead to development of uveitis. Then amiodarone, you should not forget, it can lead to optic neuropathy and corneal vortex keratopathy, cornea verticillata. Digitalis can alter the color. It makes everything look like yellow world, right? So digitalis lead to chromatopsia. Favorite MCQ in exam, you are going to remember Dr. Murli Bharadwaj in the exam hall. Chloroquine, it is used in malaria, rheumatoid arthritis, SLE. It leads to bull's eye maculopathy, is what you need to remember. It also leads to vertex keratopathy, cornea verticillata. Chlorpromazine lead to corneal punctate epithelial opacities, the psychiatric drug. Thioridazine lead to pigmentary retinopathy if you use it in high dosage. Ethambutol, it lead to dose-related optic neuropathy, usually reversible. It lead to a dose-related optic neuropathy, ethambutol. That is the story about the various drugs, doctor. Now, how do you want to treat Murren's ulcer? Topical steroids, corneal graft, immunosuppressives, all of them are used. That is the reason I always tell you, doctor, before we start discussion, if you happen to solve the questions, right? बहुत interesting लगता है. This does not look very fast. क्योंकि जब आप solve करते हैं हमारे quiz before the discussion, you are exercising your mind. That is very important, right? हाँ. So now Dr. Murren साहब 1867 में Murren's ulcer को पकड़ा. This is chronic painful peripheral ulcerative keratitis. What is Murren? Chronic painful peripheral ulcerative keratitis. Keratitis मतलब cornea, cornea में ulcer, periphery में ulcer, painful ulcer, chronic ulcer, that is Murren. Murren is more common in the case of the males. Depending on the age of onset, the Murrens can be two types. Unilateral, older, limited, and responsive to local surgical medical therapy. Bilateral, younger, progressive, resistant to systemic immunosuppression is the second type in the Murren's ulcer. So fundamentally, Murren's ulcer क्यों होता है? It is an autoimmune process, both cell-mediated and humoral immunity. Immune antigen antibody complexes get deposited. Type 3 hypersensitivity. Type 3 hypersensitivity, favorite MCQ. Murren में कौन सा hypersensitivity? Type 3 immune antigen antibody complexes. There are decreased suppressor T cells, unregulated helper T cells. They produce autoantibodies, immune complexes deposit. Proteolytic enzymes are produced and that lead to the melting of the cornea. वो होता है Murren's is what you need to remember. So progressive crescentic peripheral corneal ulceration that is slightly central to corneoscleral limbus. Limbus के आजू बाजू में आपको Murren's ulcer होता है. There is a overhanging edge and limbal cornea which is involved, typically corneoscleral junction. Limbus is the one which is involved. It has three zones. A superficial stroma which is vascularized, infiltrated with the lymphocytes with the destruction of the collagen matrix. Mid-stroma, hyperactivity of fibroblasts and disorganized collagen, and deep stroma with heavy macrophage infiltration, but Descemet's membrane and endothelium are spared. They are spared in case of Murren's ulcer. And there is a leading edge which has a severe neutrophilic inflammation. And there is an epithelial hyperplasia of the conjunctiva. And how do they present Murren's patients? Redness, lacrimation, photophobia. Pain is typically the outstanding feature of this Murren's ulcer. Excruciating pain out of proportion to the corneal inflammation, decreased visual acuity. These are all the features. There will be patchy stromal infiltrates that coalesce commonly in the region of the palpebral fissure, involvement of the limbus. That is very classical feature of Murren's. Then when the anterior 1/3 to half of the stroma is involved, then there is a steep overlying central and leading edge रहता है Murren's corneal ulcer में. The surrounding conjunctiva will all become inflamed and edematous, and glaucoma, cataract can complicate and perforation can occur, and healing and vascularization will take over another 8 to 14 weeks. And irregular astigmatism is a consequence of the Moran's ulcer. And the end stage में क्या होता? Typically scarred, vascularized, thinned cornea with a sudden relief from excruciating pain will occur in case of the Moran's ulcer. So, how do you treat? Topical steroids, this is what examiner is asking you. Conjunctival resection, immunosuppressives, rehabilitation and surgical procedure. So steroids have a role because it is immunocomplex deposition, conjunctival resection karna padta hai. Now doctor, let us look into one very interesting video on the Moran's ulcer. Moran's ulcer. So this is a 40-year-old individual. Now, in which corneal ulcer signs are more than the symptoms? Excruciating pain out of proportion to inflammation, that is Moran's ulcer. But here signs, pain hota hai symptom, magar signs are more than the symptoms. Reverse of Moran kahan hota hai? In fungal corneal ulcer is what you should remember. Now let us look at one classical case of fungal corneal ulcer, doctor. Yes. So this is one typical clinical picture of the fungal corneal ulcer, which you are able to see. Yes. Now हम इसके बारे में बात करेंगे. बढ़िया. So learning is very easy, doctor, nowadays. Once upon a time, learning was a big enigma, very difficult. कहीं किसी के पास जाके भैया जरा मुझे दिखाओ दिखाओ बोल के बोलना पड़ता है. अभी तो उतना टेंशन नहीं है, सब कुछ अवेलेबल है. ओनली पर्सनल मोटिवेशन रहना पढ़ाई करने के लिए, right? That's the reason, doctor, add some spice into your preparation, right? NEETPG preparation is like surviving a 25-year-old marriage. थोड़ा कुछ सरप्राइज डेट्स होना है, कैंडल लिट, मूनलाइट, पूल साइड पार्टी होना है, कुछ साथियों साथ में रहना है, मजा आएगा प्रिपरेशन में. So otherwise, if you are alone sitting inside the room, underlining, not looking at anybody, सीट नहीं आएगा. सबके साथ एंजॉय करो. याद रखने में different people को different तरह के methods रहता है. So that is the reason to be together will make you to remember the things better, right? So please become the part of the WhatsApp study group, doctor. We have countrywide almost 20,000 students are there on our WhatsApp groups, in various WhatsApp groups. So please do call our helpline in order to become the part of one of the onlinembbs.com WhatsApp study group. Morning 6 a.m. to night 12 p.m. क्वेश्चंस एवरी 5 मिनट्स आपको क्वेश्चन दे देंगे, आप डिबेट करो, डिस्कस करो, अपने तरीके, अपने ढंग ऑफ रिमेम्बरिंग द थिंग्स मेंशन करो. So doctor, fungal corneal ulcer, clinical signs are more severe than symptoms. Conjunctival injection, anterior chamber reaction, feathery margins, very important, elevated edges, satellite lesions, and fungal corneal ulcer. Don't forget. Brown pigmentation, hypopyon, yellow line of demarcation, immune ring of Wesley. ये जरूर पूछेगा एग्जामिनर, इम्यून रिंग ऑफ वेस्ली कहां होता है? कॉर्नियल फंगल अल्सर में होता है. नाउ सैटेलाइट लीजन ऑन द कॉर्निया, फंगल अल्सर. देन फंगल कॉर्नियल अल्सर वर्ल्ड वाइड, Aspergillus is the most common fungus. 21 to 50 years, common in males, monsoon में, early winter में, due to humidity and during harvest season में fungal corneal ulcer होता है. Vegetable matter is the predisposing factor. Filamentous fungi are the ones which affect it. Yeast also. And any indiscriminate topical antibiotic steroids का इस्तेमाल करें तो फंगल कॉर्नियल अल्सर के लिए रिस्क फैक्टर है. देयर विल बी typically any corneal surgery like penetrating keratoplasty, cataract and refractive surgery, steroid abuse, they are the predisposing factors. Then any immunosuppressants, diabetes, HIV, leprosy, they are all the risk factors. So the organisms can be septated, non-pigmented like Aspergillus. They can be pigmented like Cladosporium. They can be non-septate like Rhizopus. They can be yeast like Candida. But in case of South India, it is Fusarium. North India, it is Aspergillus. The two organisms that you need to remember when it comes to fungal keratitis. Fungi, they gain access to a corneal stroma through the epithelial defect. They proliferate, they lead to necrosis, they lead to inflammation, they penetrate the intact Descemet's membrane and they typically enter into the anterior chamber iris. If they enter, then eradication becomes very, very difficult. Now this is a early fungal ulcer, mild congestion, few symptoms. And fungal keratitis, what is the rule? Signs more than symptoms. Signs more than symptoms. That is what you typically come across. This is a posterior plaque which is formed in case of the fungal keratitis. And a lot of stromal inflammation. This can look like the stromal inflammation. This can look like a viral keratitis, but actually it is fungal keratitis. A collar button configuration is very typical of yeast associated keratitis. And this is the infected area which is being scraped using Kimura's spatula. इसको कहते हैं Kimura spatula, Japanese guy. Kimura spatula is used to basically scrape that infected area. And this is how a corneal biopsy is being collected by the ophthalmologist. If you do the KOH mount, you can see those oval shaped yeast cells. In the case of the fungal keratitis is what you should remember. Now what is the most common cause of the corneal ulcer, doctor? It is the Staphylococcus aureus, most common. Most common cause of viral corneal ulcer होता है herpes simplex. What does corneal ulcer lead to? It leads to anterior staphyloma. Staphyloma के बारे में और एक बार डिस्कस करेंगे, but now intercalary staphyloma. This is called intercalary staphyloma. You have iris, no doctor? Between the two irides, if the cornea is bulging out, intercalary staphyloma. And typically intercalary staphyloma is associated with secondary angle closure glaucoma that is leading to that protrusion. So this is another example of a staphyloma where you can see the iris tissue, right? So accordingly, staphylomas are divided into anterior staphyloma, which can be intercalary or ciliary, equatorial staphyloma, posterior staphyloma होता है myopic individuals में. Myopia में there is an overall degeneration of the sclera that lead to the scleral weakening, leading to the development of the posterior staphyloma is what you should remember. And this is another example of anterior staphyloma, classical of anterior staphyloma. Bhaiya, anterior staphyloma is a sequelae of a corneal ulcer. Corneal ulcer हो गया तो anterior bulging होता है, that is anterior staphyloma. And this is intercalary staphyloma, right? And typically any incarceration of the ciliary body during a trauma in ciliary region or scleritis or a end stage glaucoma, developmental glaucoma, इन सारे चीजों में intercalary staphyloma होता है. Now this is the equatorial staphyloma. You can see equatorial staphyloma. This happens in scleritis, pathological myopia. Even this also happens in pathological myopia, and chronic uncontrolled glaucoma. So typically when there is any, this is an example of a posterior staphyloma. Posterior bole to you can't see it anteriorly. You have to do investigation like ultrasound, where you can see the protruding, bulging posterior staphyloma can be appreciated if you happen to do the ultrasound. And this you can see the degenerative changes which are common in the choroid, sclera, retina, in case of the eye, in case of pathological myopia. So it is the pathological myopia where you see the posterior staphyloma. So that brings us to the end of our first part of the game. Ramita, Radhika, Vinay, Shobit, Abhinesh, Rahul, जागो दर्शकों, नींद से जागो मेरे प्यारे दर्शकों, right? Now, so that is the reason whenever you are attending this live session, no doctor, एक pen paper बाजू में रखना, और anything that we are emphasizing, just make a small note. भैया मैं revision करूँगा, जो emphasis हो रहा है, और मैं onlineMBBS.com वीडियो लाइब्रेरी को सब्सक्राइब करके वहां ये पावर पॉइंट मिल जाएगा आपको, ठीक है? तो ये पावर पॉइंट मिल जाएगा, ये वीडियो भी मिल जाएगा, राइट? दोबारा वीडियो सुनने का जरूरत नहीं है क्योंकि ऑलरेडी आप सुन लिया, मगर पावर पॉइंट के अंदर यू हैव ऑल द स्लाइड्स व्हिच आर टॉकिंग अबाउट सम इंपॉर्टेंट अंडरलाइंग 4-5 कॉजेस एक्सेट्रा. सो फट रिविजन करो, माइंड के अंदर बिठाओ, एग्जाम हॉल में जाओ, और 10 out of 10 in ophthalmology you have to make it up, right doctor? Now get ready for the next quiz के लिए तैयार. So just walk into the kitchen, tell mama to prepare a nice coffee, right? Strong South Indian filter coffee, and coffee पीते हुए फटाफट next quiz का आंसर करो. मैं भी किचन में जाके जरा कॉफी पी के आता हूं, और बाद में हम सब इसको रिव्यू करेंगे. नाउ डॉक्टर, इन द सेकंड क्विज वी हैव 40 क्वेश्चंस. वी विल कीप 15 सेकेंड्स, 10 मिनट्स ब्रेक ले लेंगे. इतने में 10 मिनट्स में आप खत्म करो क्विज को. जरा स्लो में लगाएंगे, 10 सेकेंड्स, एंड द साउंड होता है कैश रजिस्टर, राइट? अप्लाई टू ऑल. Right. So डॉक्टर शुरू हो जाए हमारा नेक्स्ट जर्नी। Am I very late? No, right? Okay. So, welcome back to everybody. Let us continue our journey. Uday, Abbas, Rituraj, Satapati, and many more who are all online. आज हम ऑफ्थल्मोलॉजी को अंत देखेंगे. Retinal detachment. The question is, where does retinal detachment happen? Between which layer and which layer? Please punch your answers, doctor. Yes. Retinal detachment occur between sensory and the pigment layer के दोनों के बीच में होता है. भैया, this is the sensory retinal layer. ये दिख रहा है ना? Then this is the pigment retinal epithelium. इन दोनों के बीच में separation होता है. Retinal detachment is what you have to basically remember. So whenever there is any retinal tear, there is a subretinal fluid leading to the development of the retinal detachment and even the vitreous detachment. This is how, if you happen to look through the fundus, the retinal detachment with the fluid underneath, with the separation happening, looks like the retinal detachment looks like, is what you should remember. Now, what are the layers of the retina, doctors? First, let us be very clear. Nerve fiber layer, ganglion cell layer, inner plexiform, inner nuclear, outer plexiform, outer nuclear, photoreceptor and pigment epithelium. ये photoreceptor जो sensory layer है और pigment epithelium which is the last one, between these two the separation is what you see in the case of the retinal detachment is what you should remember. A hypertensive pregnant patient presented to you with a sudden painless loss of vision, what is the possible cause? Now we have reached one of the favorite area of the examiner, that is causes of tractional, exudative and rhegmatogenous retinal detachment. What are the causes? You should be very sure. So, a retinal detachment, first of all, is a separation between NSR and RP. That is neurosensory retina and retinal pigment epithelium के बीच में separation होता है, the retinal detachment. It can be rhegmatogenous, it can be tractional, it can be exudative. Regma होता है, regma means break. Right? Regma, रेशमा नहीं, regma होता है break. Kshitish Raj is saying, sir, do not understand retinal detachment. इसमें अंडरस्टैंड नहीं होने का कुछ भी बात नहीं है. कोई रेटिना को आगे से खींचता है ट्रैक्शनल, कोई रेटिना को पीछे से पुश करता है, that will be exudative. So जब भी रेटिना के अंदर एक होल हो जाता है, उसके वो होल के अंदर से फ्लूइड जाके सेपरेट करता है, वो है rhegmatogenous. Rhegmatogenous, tractional, exudative. Three types by which the retina, the neurosensory and the pigment epithelium are separated from each other. That is, now Raj is expert in retinal detachment. Rhegmatogenous is a full thickness defect in the sensory retina. It will permit the fluids which are derived from the liquefied vitreous to gain access into the subretinal space through a small break. जहां ब्रेक होता है, रेगमा होता है, rhegmatogenous retinal detachment. Tractional. Whenever there is any fibrosis happening into the vitreoretinal membrane, they undergo contraction and they pull the neurosensory retina away from the retinal pigment epithelium. वो होता है Tractional is what you should remember. Exudative, there is no brake, there is no traction. But the choroid tissue होता है ना डॉक्टर, choroid में blood vessels होते हैं. These blood vessels in the choroid produce a lot of subretinal fluid. That is exudative. Exudative में regma नहीं है, exudative में traction नहीं है, exudative में exudation है. कहाँ से हो रहा है वो? Choroidal blood vessels से हो रहा है. That is what you need to remember. Anything is easy, doctor, provided you should know that finest logic समझना है आप. That is very important, right? So very good. Abhishek Vyas says, "Badhiya, vare vah." So, doctor, one of the student gave a very good compliment in my videos. My video published होने के बाद YouTube में, you think that I will forget? No, I will eagerly look forward if there are any comments. Your little compliments make the teacher very happy. कोई लिखा है कि सर आप ऐसे पढ़ाते जाओ, नॉन मेडिकल लोग भी नीट पीजी लिखना शुरू कर देते. हाँ. So always, doctor, let me tell you, you understood the subject or not, only there is one sign about it. If you can explain to somebody else एक pen paper लेके clarity के साथ अगर आप किसी को समझा सके तो that means you understood. So that is the reason always have a very good group of friends with whom you should study together in the reading room. Then there can be a combined tractional rhegmatogenous दोनों होता है pathology में. That is a typical feature of advanced proliferative diabetic retinopathy में ऐसे combination होता है. There can be a dynamic traction, there can be a static traction. Whenever eye movements are there, traction हो रहा है, वो होता है dynamic. Ocular movements कुछ भी नहीं है, traction हो रहा है, that is static. Dynamic traction is the important role in the pathogenesis of retinal tear and rhegmatogenous retinal detachment. Static traction is what you see whenever there is any proliferative vitreous retinopathy. That is a static traction. Without eye movement only, traction keeps happening. That is typically the proliferative vitreous retinopathy. The main cause of the traction retinal detachment are two things. One is proliferative retinopathy like diabetic retinopathy, prematurity retinopathy, or any penetrating trauma to the posterior segment will lead to development of tractional retinal detachment. Exudative retinal detachment का 5 causes. फटाफट बोलो डॉक्टर, before I give you gold medal. Uveitis, Wompt-Koyanagi-Harada syndrome. uveitis में भैया uveal tract क्या होता है? Iris, ciliary body, choroiditis will lead to retinal displacement, creating subretinal fluid. So uveitis, choroidal tumors like malignant melanoma or any metastasis, any low blood protein levels, hypertension, eclampsia, hypothyroidism, choroidal effusion syndrome, ये सब चीजों में होता है exudative retinal detachment. भैया ये क्वेश्चन हर एक बार पूछता है एग्जामिनर, eclampsia में what type of retinal detachment होता है tractional retinal detachment, exudative, not tractional, exudative retinal detachment in case of eclampsia is what you should remember. Tractional, it is caused by the traction like diabetic retinopathy, CR-VO, central retinal venous occlusion में hypoxia होता है. Hypoxia की वजह से neovascularization lead to hemorrhage lead to fibrosis lead to traction, vitreous fibrosis lead to traction. So CR-VO, sickle cell disease, retinopathy of prematurity, ocular trauma, they are the causes of tractional retinal detachment. So if you look at the exudative retinal detachment, doctor, there are ocular causes, systemic causes. Systemic में toxemia of pregnancy, renal hypertension, blood dyscrasia, polyarteritis nodosa. Like a parrot, कल के एग्जाम में आप फटाफट आंसर करना. Especially टॉक्सीमिया ऑफ प्रेगनेंसी में क्या होता है? एक्सुडेटिव रेटिनोपैथी होता है, एक्सुडेटिव रेटिनल डिटैचमेंट होता है। डिट्टो डिट्टो क्वेश्चन आएगा कल एग्जाम में, आंसर करते हुए आप हंसते सोचेंगे कि ओ दैट डे ऑन दैट यूट्यूब ब्रॉडकास्ट, वाओ आई बिकेम एक्सपर्ट इन रेटिनल डिटैचमेंट बोलेगा। आप लोगों में कुछ लोग एमिनेंट ऑफ्थल्मोलॉजिस्ट बनने के लिए पैदा हुए हैं। So you will definitely, I will get the privilege that I was the one who was revising you the retinal detachment in that year, right? Harada's disease, sympathetic ophthalmitis, partial sternitis, orbital cellulitis, ocular causes, central serous retinopathy, exudative retinopathy of coat, and similarly malignant choroid lesions, malignant melanoma of choroid, retinoblastoma, any sudden hypotony because of the proliferation of the globe of intraorticular operations are increasing, no, that also predisposes to exudative retinopathy. This is one slide, फोटो खींच के जेब में रखो ताकि कल के एग्जाम में जरूर यूजफुल होगा। Regmatogenous भैया liquefied vitreous that passes through the retinal break होता है regma. Subretinal exudation is exudative. Any proliferative membranes that contract and elevate the retina होता है tractional. So proliferative vitreoretinopathy, diabetic retinopathy, retinopathy of prematurity, Coats disease, sickle cell disease, Norris disease, uveitis, toxocariasis, pars planitis, tumor, penetrating trauma, they all lead to tractional. Similarly, all the causes of the exudative, all the causes of the regmatogenous. Myopia में होता है regmatogenous. Myopia lead to degeneration. Degeneration creates regma, that is the break. So myopia में होने वाला retinal detachment होता है regmatogenous retinal detachment. Aphakia में regmatogenous retinal detachment. ND याग capsulotomy में regmatogenous retinal detachment. These are the things you have to very clearly understand out there. अगर fundus देखें तो what are the differences between regmatogenous, exudative and tractional? Convex borders, corrugated surface, clear subretinal fluid and the bullae and folds that undulate with eye movements, that is regmatogenous, dynamic होता है। Exudative में convex borders, only tractional में concave borders. Very important question in the exam. Smooth surface, volume and gravity dependent is exudative. Subretinal fluid can be turbid and it moves according to the gravity. Whereas immobile retina, elevated and taut retina and concave borders, that is the feature of tractional. Please don't forget, doctor. Then ultrasound करें तो there is a membrane within the vitreous cavity with high reflectivity and a high spike on A scan, and it is mobile with eye movements. That's how regmatogenous retinal detachment present. A dome-shaped hyperechoic lesion on the retina, it tends to adopt to the dependent position. वो होता है exudative. A membrane within the vitreous cavity with high reflectivity on A scan, immobile with eye movement with a funnel configuration. That is what you see in tractional. Then regmatogenous retinal detachment is associated with a posterior vitreous detachment, a posterior hyaloid face with low reflectivity, low spike on A scan and very mobile with eye movements associated with regmatogenous retinal detachment. The fundamental differences you have to be very sure about. Now, doctor, these are all the predisposing factors for the regmatogenous retinal detachment. Now it is a game, right? Diabetic retinopathy में होता है tractional retinal detachment. That is what you need to remember. Whereas myopia, trauma, aphakia, you have a regmatogenous retinal detachment. Treatment of tractional retinal detachment होता है pars plana vitrectomy, because vitreous के अंदर fibrosis खींच रहा है. It is pulling the retina. So उस vitreous को remove करो, pars plana vitrectomy. Schaffer's sign, where do we see? Schaffer sign is seen in the case of the retinal detachment. भैया Schaffer क्या होता है retinal detachment में? There is a tobacco dust in the anterior vitreous. It is pathognomonic of retinal tear. Retina में tear हो गया तो there will be pigment into the anterior vitreous which is called Schaffer sign, which is a sign of rheumatogenic retinal detachment. The presence of pigment granules in the anterior vitreous इसको कहते हैं tobacco dust. Anterior vitreous को कहते हैं बर्जर स्पेस. बर्जर्स स्पेस में tobacco dust, Schaffer sign, rheumatogenic retinal detachment is what you have to basically remember. Now, what is the investigation of choice if you are suspecting retinal detachment? Indirect ophthalmoscopy देखे तो पूरा periphery of the retina दिखता है. That is the reason it is the best investigation. भैया direct versus indirect ophthalmoscopy. Direct and indirect ophthalmoscopy. डायरेक्ट होता है वो पकड़ के पेशेंट के बाजू जाके आपके आंख से उनके आंख में मोनोक्युलरली देखना, वो होता है डायरेक्ट. इनडायरेक्ट यू आर वेरी फार अवे फ्रॉम पेशेंट, वो लेंस लगा के उसके आंख के अंदर देख रहे हैं, आपके दोनों आंखों से देख रहे हैं, इसलिए इट्स ए बाइनोकुलर व्यू. सो बाइनोकुलर व्यू इज इनडायरेक्ट, मोनोक्युलर इज डायरेक्ट. लिमिटेड फील्ड ऑफ व्यू इज डायरेक्ट, एक आंख से ही देख रहे हैं आप. वाइड फील्ड 35 degrees is indirect, is what you should remember. And if the medium is hazy, there is a poor view. Even in hazy medium, it is a better view. Imagine you are flying on aeroplane and watching the city below, है ना? तो जरा क्लाउड्स है तो भी आपको सिटी दिखाएगा, हेजी मीडियम है तो भी दिखाएगा. उतना ऊपर से सिटी को देख रहे हैं आप एरोप्लेन के विंडो से, दैट इज लाइक इनडायरेक्ट ऑप्थेल्मोस्कोपी. सो बेटर व्यू इन हेजी मीडियम. और डायरेक्ट ऑप्थेल्मोस्कोपी में आप पेशेंट के आंख से आंख मिला के बहुत नजदीक जाना है. आपके मुंह में बदबू है, पेशेंट के मुंह में बदबू है, टेंशन हो जाएगा. So that is the reason you have to be very close to the patient, whereas the working distance in the case of the indirect ophthalmoscopy is 35 to 40 centimeters. You can draw the retinal lesions, but very difficult and incomplete if it is direct. But in case of indirect ophthalmoscopy, दूर से देख रहा है, पूरा wide range को देख रहा है. आप ऊपर ये लीजन है, nasal में ये लीजन है, temporal में ये लीजन है, बोल के पूरा लिख सकते. You can be able to draw if it is indirect. It is difficult to use during surgery, obviously, but it can be used indirect ophthalmoscopy. Then you should also remember the illumination is 0.5 to 2 watts in case of direct, whereas illumination is 15 to 18 watts in case of indirect. मैग्निफिकेशन इज 15 टाइम्स इन डायरेक्ट. बहुत नजदीक से देख रहे हैं ना, मैग्निफिकेशन बढ़ा रहता है. दूर से देख रहे हैं एरोप्लेन से, इसलिए इनडायरेक्ट में ओनली 2 to 5 टाइम्स मैग्निफिकेशन. वर्चुअल इरेक्ट इमेज होता है डायरेक्ट, रियल इन्वर्टेड इमेज होता है इनडायरेक्ट, रियल इन्वर्टेड होता है इनडायरेक्ट. दैट इज व्हाट यू हैव टू बेसिकली रिमेंबर. नाउ डॉक्टर, व्हेन यू सी शार्पर स्ट्राइन रेटिनल डिटैचमेंट में, most common cause of retinal detachment is typically myopia, pathological myopia. Now comes visual field defects. Bilateral temporal hemianopia. Where do you see? Whenever there is any pituitary adenoma, it is compressing the optic chiasma. Then what happens, doctor? You are having an optic nerve this side, optic nerve this side. This is becoming chiasma. Chiasma में क्या है? Chiasma में uncrossed temporal and crossed nasal, uncrossed temporal है. That is the reason any compression of it will lead to bitemporal hemianopia. Bitemporal hemianopia is typically caused. Now this is one thing, doctor, you have to be very sure. Definitely one question will come on the visual field effects. Very easy. पूरा ऑप्टिक नर्व गड़बड़ हो गया, इप्सिलेटरल मोनोक्यूलर विजन लॉस, ऑप्टिक चायस्मा में दिक्कत है, देन यू गेट बाई टेम्पोरल, इस साइड का टेम्पोरल, उस साइड का टेम्पोरल. क्यों? क्योंकि optic chiasma is the area where the two nasal are crossing and the two temporal are uncrossing, and optic chiasma ke compression typically happens centrally, but means a crossing wale nasal fibers are affected, and that is the reason both the sides temporal are gone. That is what you should remember. Any lesion of the optic tract, एक optic tract लिए तो उसमें क्या होता है, एक साइड का uncrossed ipsilateral, uncrossed temporal and contralateral nasal fibers are there. इसलिए contralateral temporal गया और ipsilateral nasal visual field गया. That is called contralateral homonymous hemianopia. Then any parietal optic radiation, if it is affected, then there is a contralateral homonymous inferior quadrant anopsia. Inferior होता है parietal, superior होता है temporal. Inferior होता है parietal, right? Superior होता है temporal. So contralateral homonymous superior quadrant anopsia होता है if the temporal optic radiation is affected. And ultimately occipital visual cortex affect हो गया तो contralateral homonymous hemianopia with the macular sparing. Macula is the central vision. Macula is the area of visual acuity, highest visual acuity. That is the reason भगवान ने ऐसा दिया कि macula area of the visual cortex को double blood supply दे दिया. इलेक्ट्रिसिटी में फेज 1 फेज 2 होता है, फेज 1 गए तो फेज 2 का बल्ब जलता, फेज 2 गए तो फेज 1 का रहता. वैसा ही macula also is being supplied by both the posterior cerebral artery and also the middle cerebral artery. So that is the reason it won't get completely gone unless there is a very significant brain lesion, right? So contralateral homonymous hemianopia macular sparing is a feature whenever there is a occipital visual cortex involvement. That is what examiner is going to ask. So will you all promise me? कल के एग्जाम में विजुअल फील्ड डिफेक्ट का क्वेश्चन कहाँ है बोल के देख के पकड़ के खत्म करो, like बाहुबली. You have to fight in the tomorrow's exam, doctor. Be very sure. You're all the students of Dr. Murli Bharadwaj means you are all guns, missiles, like the American snipers. टक 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 करेक्ट आंसर करके बाहर निकलना है. एवरी टॉपिक में 5 to 6 सूक्ष्म बात होते हैं, उसको समझने के बाद ही आपको मिलेगा मोक्ष. नीट पीजी से मोक्ष, ठीक है? तो आपको मोक्ष दिलाने के लिए हम मुरली भारद्वाज यहाँ हैं. So lesion of the occipital lobe, what does it lead to? Homonymous hemianopia contralaterally with the macular sparing. Macular sparing. So macular sparing typically occur because macula is both supplied by posterior temporal artery, which is the branch of the posterior cerebral artery, and also by the middle cerebral artery. दोनों supply करता है macula को. But yeah, this is an interesting concept. If you look at the lesions of the visual cortex, you can get congruous homonymous hemianopia sparing macula. One more important point you should know. आपके ऑप्टिक पाथवे में क्या क्या है भैया? आपको क्या क्या मिलेगा? आपको रेटिना, ऑप्टिक नर्व, then optic chiasma, optic tract, then there is a lateral geniculate body. Lateral geniculate body, then comes the optic radiation, and finally you are reaching the visual cortex. भैया geniculate body के आगे versus geniculate body के पीछे, there is a difference. What is the difference, doctor? Typically those lesions which are posterior to the geniculate, posterior to the geniculate, posterior to the geniculate, they will be congruous. Whereas those lesions which are anterior to the geniculate will be incongruous. भैया congruous क्या होता है, incongruous क्या होता है, बोलो. Let us say there is a homonymous hemianopia, मतलब दोनों temporal fields are affected, let us say. But the amount of the field which got affected in right eye and left eye, if it is same, that is congruous. If the amount of the involvement is more in one eye, दोनों में temporal है, पर temporal of one eye is more involved than the temporal eye of the other field, right? Then that is called incongruous. Pre-geniculate lesions are all incongruous. Post-geniculate lesions towards visual cortex are all congruous. That is what you need to basically remember. So congruous homonymous hemianopia post-geniculate lesion में होता है. But if it is pairing macula, then it is occlusion of posterior cerebral artery. But if it is involving macula, then most likely that there is a lesion of the tip of the occipital cortex. That's what you need to remember. So, doctors, what is lesion of optic tract? What will it produce? Optic tract will produce a contralateral homonymous hemianopia. What lead to involvement of optic tract? Optic tract is involved in syphilis, TB, and tumors of the optic thalamus, and any aneurysm of the superior cerebellar or posterior cerebral arteries, and it is pre-geniculate. Obviously optic tract geniculate के आगे है, जो आगे होता है geniculate के आगे उसको कहते हैं pre-geniculate. Pre-geniculate होता है incongruous, is what you need to remember. It leads to incongruous homonymous hemianopia with Wernicke's reaction. This is another tension. भैया Wernicke tension, Wernicke reaction क्या होता है? What is Wernicke reaction? See, the two retinas are giving rise to optic nerve that is undergoing the crossing and forming the optic chiasma. I mean optic tract, बराबर? So optic tract involve हुआ, then what will happen? Ipsilateral, temporal, contralateral, nasal fibers are affected. So that part of the visual field where the hemianopia is there, temporal or nasal, there if you throw the light, right, then there is no light reflex. Pupils won't constrict. But suppose if temporal is involved, temporal visual field is involved, then temporal visual field के ऊपर अगर आप light लगाए तो, temporally light लगाए तो, there is no pupillary reaction. But if you move it to nasal side and put the light, then pupil constricts. This kind of a reaction that happens in hemianopic lesions is called as Wernicke's reaction, is what you have to remember. Now, hemianopia का मतलब क्या होता है? The lesion of the vision, the lesion in the vision in one half of the visual field, right or left, is called hemianopia. Half is called hemianopia. One quadrant is called quadrantanopia. ये तो easy है remember करने के लिए. Homonymous क्या होता है? Same halves of the visual field. इधर का temporal, उधर का भी temporal. Heteronymous होता है इधर का temporal, उधर का nasal. नहीं तो उधर का इधर का nasal और उधर का temporal. That becomes heteronymous. So whenever optic chiasma is involved, doctor, there is a bitemporal hemianopia. Whenever pituitary glandular meningioma is compressing the optic chiasma, then you get bitemporal hemianopia. Bitemporal hemianopia. Then retrochiasmal, chiasma के पीछे, any lesion of the left optic tract or lateral geniculate body or optic radiation or visual cortex, it will all lead to right homonymous hemianopia. मतलब इधर का temporal, उधर का nasal get involved. Then Any lesion of the optic radiation in the temporal lobe will lead to superior quadrant myopia. इसको कहते हैं pie in the sky. Pie in the sky typically happens with the temporal lobe lesions. And any bilateral visual cortex lesions हुए तो then you get macular sparing. So this is what you have to be 100% sure about. Now, doctor, right homonymous hemianopia. What is responsible? What leads to it? It is a left optic radiation, always contralateral homonymous hemianopia. समझ में आ गया ना? अगर लेफ्ट का ऑप्टिक रेडिएशन में दिक्कत है तो राइट में होमोनीमस हेमियोनोपिया. राइट होमोनीमस हेमियोनोपिया इज इन द लेफ्ट ऑप्टिक रेडिएशन. पिट्यूटरी ट्यूमर ऊपर से दबाव डाल रहे, देन क्या हो जाएगा? बाइटेम्पोरल हेमियोनोपिया. एल्टीट्यूडिनल फील्ड एकदम एल्टीट्यूड निकल जाएगा. कहां होता है? Typically in anterior ischemic optic neuropathy, which happens in giant cell arteritis. If you don't jump and give steroids in giant cell arteritis, it lead to blindness because it lead to anterior ischemic optic neuropathy is what you should remember. So भैया ये होता है altitudinal field defect, inferior altitudinal field defect है ये सब. So ischemic optic neuropathy में there is an acute ischemia of optic nerve. Elderly people में the common optic neuropathy is ischemic optic neuropathy. Typical age of the patient is between 55 to 70. So ये इश्क कब होता है? Ischemic optic neuropathy can be anterior or posterior. Posterior ischemic optic neuropathy typically happens when there is any posterior part of the optic nerve is ischemic. Anterior ischemic optic neuropathy can be arteritic, non-arteritic. Giant cell arteritis lead to arteritic anterior ischemic neuropathy and non-inflammatory. What are the symptoms? Whenever optic nerve is damaged due to ischemia, ishq ho gaya to, there is acute loss of vision in eyes. It is painless, 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 painless. Please don't forget, favorite question of the examiner, anterior ischemic optic neuropathy is a painless loss of vision, not a painful. Favorite question. Then visual field loss, then relative afferent pupillary defect and Marcus gun pupil, swollen optic disc, flame shaped hemorrhages, ये सब चीजें होते हैं anterior ischemic optic neuropathy में. Now anterior is most serious type. Giant cell arteritis is that systemic inflammatory vasculitic condition that lead to development of anterior ischemic optic neuropathy. Even polyarteritis, notice the SLE, herpes zoster, anything can affect. Females in their 60s are the risk factors. There's a sudden unilateral painless visual loss and RAPD, that is relative afferent pupillary defect, altitudinal field cut and dyschromatopsia. Periocular pain and flashing will occur. And periocular pain is different. Periocular pain is different and flashes can occur. There is a pale and swollen optic disc which is chalky white with a hyperemic swelling that characterizes the features. So pale optic disc edema with adjacent retina infarcted, then pain will happen. Then chalky white pale swollen hyperemic optic disc is the classical feature. Then before developing, this is a normal. Then 1 week after developing, you can find a chalky white optic disc and edema. And 4 months later, there is an optic disc cupping and cup disc ratio increased to 0.8. These are the features of ischemic optic neuropathy. Anterior ischemic optic neuropathy is the one which lead to the development of altitudinal field cut is what you should remember. Now comes an interesting question. Which order neuron optic nerve is having? Optic nerve is having the ganglionic cell axons. Ganglion cell का axons है optic nerve में. They are the second order is what you should remember. First order is bipolar cells of retina, second order ganglion cells of retina, third order are the neurons in the 6 layers of the lateral geniculate body. Lateral geniculate body. They are the third order. Please don't forget, doctor. This is a favorite question of the examiner. So first order nerve cell is bipolar cell in the inner nuclear layer of the optic nerve. Second order neuron is the ganglion cells, nerve fiber layer that goes to optic nerve. Now what does optic tract lesion lead to? Optic tract leads to homonymous hemianopia is what you should remember. Now doctor, the next topic is corneal ulcer. मेरे प्यारे साथियों, भूख लग रहे हैं क्या? रोटी कपड़ा मकान, इसके लिए ही हम जीते हैं पूरी जिंदगी. So we'll finish this and then we'll have a 1 hour lunch break. Am I going too fast or is it okay? Can you please punch? Can you please punch? मेरे प्यारे पंछियों, please punch. Whether am I going too fast? You want me to go little slow? Slow गए तो मजा नहीं है, ये तो रिवीजन है. जनवरी 5th का घंटी बज रहा है. Okay, says Rituraj. Okay. So, Dr. Klebsiella pneumonia typically lead to keratitis. Salmon patch, ये तो most recent FMG exam का question है. So, it is interstitial keratitis. This is the syphilitic. Perfect speed for revision. कह रहा है हमारे तौशीद शेख. Absolutely, doctor. Thank you so much. हम बहुत खुश हैं. तौशीद शेख, देवियन डे, अंकित शर्मा, Dr. Atul. Dr. Atul always tells, he's the one who says, please take rest, please take care, good night, sir. Huh? So, very good. The other day, early morning, 1 o'clock, I delivered a class. I just want to check. कितना सीरियस है हमारे बच्चे. There are almost 50 students. Till early morning 3 o'clock we are having discussion. अरे वाह, हम बहुत खुश हैं, right? So now doctor, syphilitic interstitial keratitis. There are deep stromal vessels in the retroillumination and perivascular leukocytic cuffing. They are the classical features of interstitial keratitis. भैया इसको कहते हैं the salmon patch is what you should remember. Now, in case of neurotropic keratitis, which nerve is involved? Neurotropic. Obviously, the sensory supply to the overlying cornea is from the trigeminal. Interstitial keratitis होता है syphilis में. Acanthamoeba keratitis का treatment क्या है? We give propamidine isothiionate to treat the acanthamoeba. Steroids के बारे में बात मत नहीं करना क्योंकि steroids are a risk factor to get acanthamoeba keratitis. That is what you should remember. Acanthamoeba keratitis is progressive. It is seen in immunocompetent. And any poor contact lens hygiene, corneal abrasion, or exposure of the eye to contaminated water. Very important, doctor. कुछ आंख में लग गए तो it is our tendency to run to the tap water and try to wash the eye. Never do that. That is the common source for the development of infection. Very, very important. Now, how does acanthamoeba present? Eye pain, redness, sensitivity, photophobia, excessive tearing, conjunctival hyperemia, epistolitis, scleritis, and loosening of the corneal epithelium. And if the trophozoites can be able to swim, they swim and lead to chorioretinitis can be the consequence. How do you diagnose? CSF wet mouth, usually lymphocyte predominance and low glucose, motile trophozoites. Culture agar plates seeded with E. coli are used. We do PCR, we do corneal scraping and biopsy. So contact lens wearers, more than 90% of acanthamoeba keratitis, both the soft lens, rigid lens, दोनों में होता है. Swimming in lenses, non-compliance with the contact lens disinfection systems, they are the predisposing factors. Usually it is unilateral. Soft lens have a higher risk than the daily wear rigid lens. And You should always have a high index of clinical suspicion. Any chronicity, multiple physician referrals, culture negative scrapings, resistance to antimicrobials, previous steroid use history, any indolent nature of the disease, they are all the integral feature of making a diagnosis of acanthamoeba keratitis. It will present like a foreign body sensation, photophobia, intractable pain, and early disease may what do you find? Epitheliopathy, punctate keratopathy, pseudodendrites, radial keratoneuritis, any of them can be the presenting feature of the early disease is what you should remember. This is the early acanthamoeba keratitis with epitheliopathy and epithelial infiltrates. These are subepithelial irregularities, pseudodendrites, epithelial ridges, any of them can be the feature. There can be ring infiltrates, frank ulceration, anterior-uveitis, corneal melting, corneal perforation, anything can happen in the late disease. This is the sterile anterior uveitis, ring abscess, please don't forget, corneal meltdown, the features of acanthamoeba keratitis. Extracorneal, there can be limbitis, scleritis, uveitis, eyelid edema, dactylioidinitis, anything can happen. So how do you treat, doctor? We give aminoglycosides to inhibit protein synthesis like neomycin, perimomycin. Aromatic diamidins, this is what examiner is asking. They inhibit DNA synthesis. Propamidin, isethionate and hexamidin are the ones which are used in acanthamoeba keratitis. फिर कल के एग्जाम में आएगा, मेरे साथ और एक बार बोलो, propamidin, isethionate, ethionate and hexamidin are the aromatic diamidines. Raj is saying, sir, Salman patch is looking like Arcus senilis. Yeah, because of both of them are interstitial pathologies, no doctor, interstitial deposition. तो दिखने में एक ही होता है, मगर history and all those things are important. Then biguanides like polyhexamethylene biguanide and chlorhexidine can be used in acanthamoeba keratitis. Imidazoles, clotrimazole, fluconazole, ketoconazole can very much be used for acanthamoeba keratitis. Now doctor, acanthamoeba keratitis, what is it associated with? It is associated with soft contact lens wearing, which will not penetrate the cornea. Pseudomonas does not penetrate the cornea. They are the important issues. Now comes the next topic, doctor, retinoblastoma. Knudsen's double hit hypothesis. This is FMGE 2017 का question है. You should remember retinoblastoma gene. भैया ये नॉर्मल क्रोमोसोम्स है मैटरनल एंड पैटर्नल का, यहाँ एक ट्यूमर सप्रेसर जीन है. देयर इज अ ट्यूमर सप्रेसर जीन. फर्स्ट हिट में म्यूटेशन होगा इस सप्रेसर जीन के अंदर. सेकंड हिट में देयर इज अ लॉस ऑफ द वाइल्ड टाइप ऑफ क्रोमोसोम एंड दैट लीड टू कंप्लीट लॉस ऑफ द ट्यूमर सप्रेसर जीन. दिस इज कॉल्ड Knudsen's double hit hypothesis leading to two mutations. Tuck will lead to retinoblastoma. Most common primary intraocular tumor is retinoblastoma. Commonest site of distant metastasis of retinoblastoma, it goes to brain. This is something that you need to remember, doctor. Rees-Ellis-Worth system. रेटिनोब्लास्टोमा को क्लासिफिकेशन के लिए Rees-Ellis-Worth system is the one which is used. Don't remember what it is, just to know the name, more than enough for the entrance. So retinoblastoma can occur both familial and sporadic forms. Familial होता है multiple bilateral, unifocal, unilateral and high risk of developing osteogenic sarcoma. The second tumor which develops because of the RB gene involvement is osteogenic sarcoma. Sporadic cases are non-heritable, unilateral, unifocal. Bilateral hota hai familial cases. One of the favorite question of the examiner. Now, how do you evaluate retinoblastoma, doctor? Complete pediatric history, complete blood picture, MRI, lumbar puncture, bone marrow, bone scan. Now, a child with retinoblastoma, what will he have? Esotropia, दोनों आंखें नाक को देख रहे हैं. Esotropia. They both got deviated out. Exotropia. Esotropia होता है retinoblastoma में. भैया रेटिनोब्लास्टोमा का स्टोरी क्या होता है? फैमिली हिस्ट्री 10%. Leukocoria is commonest presenting feature, which is the white pupillary reflex. Esotropic strabismus is found in about 1/5 of cases. It leads to ocular inflammation. Pseudo-hypopion, because tumor cells will enter into anterior chamber. It look like hyphema, इसलिए इसको कहते हैं pseudo-hypopion. Is the one which you see in case of retinoblastoma. It can lead to angle closure glaucoma. Trilateral retinoblastoma बोले तो क्या है? Bilateral retinoblastoma दोनों आंखों में, along with pinealoblastoma, सब मिला के उसको कहते हैं trilateral retinoblastoma, and it can lead to distant metastasis. Now, the most common intraocular malignancy of childhood is retinoblastoma. 1920, exactly 100 years back, Varnov is the guy who said, इसको कहते हैं, this cat's emerotic reflex, that white reflex in this little bachu, this is retinoblastoma बोल के नाम दिया. Then it is a tumor of neuroepithelial origin, and it is arising from the nucleated cells, layers. Slightly more in boys, more than 90% cases before 5 years of age, right? Now, unilateral in 80%, bilateral in 35%. Hereditary cases 12 to 14 months में पकड़ा जाता है, 24 to 30 months if it is sporadic cases. So any new patient, 10% family history, 90% no family histories. 10% में they are all bilateral heritable. Then 90% no family history में 20 to 30% bilateral and 70 to 80 are unilateral. At this 20 to 30% bilateral heritable, then 70 to 80 में 10% are unilateral heritable, 60 to 70 are unilateral non-heritable. That is what is the typical statistics. Then chromosome 13 is retinoblastoma. 13 means puberty. Puberty means you will start appreciating the opposite people, opposite sex, right? So तब से आपके आंख really देखना शुरू करता. So retinoblastoma 13, easy to remember. So Alfred Knudsen's double hit hypothesis, he said hereditary or familial, germline mutation, bilateral, multifocal, young age. Non-hereditary or sporadic with 2 hits, unilateral, unifocal, older age. That's what you need to remember. They can locally spread through optic nerve, through central retinal veins. Distant metastasis can go to CNS, skull, bones, lymph nodes, brain, and orbital involvement. So how do you diagnose, doctor? Direct ophthalmoscopy may white reflex. Indirect ophthalmoscopy may you can see it projecting into vitreous like a creamy white in color with neovascularization and a cottage cheese appearance. That's how you identify. Then B scan is important for retinoblastoma. A scan is for the retinal detachment. So B scan may you can see the presence of the retinoblastoma. CT scan may you will find it like a heterogeneous lesion with a hyperdense foci because of the calcification. Very classical feature. You can also appreciate whether there is any involvement of the optic nerve, the tail ko bhi involvement ho gaya. Then MRI, if you want to look for optic nerve, extraocular extension, trilateral retinoblastoma, pineal gland में भी है क्या देखने के लिए, you use the MRI. Then aqueous humor में LDH5 to LDH1 isozyme ratio become elevated. Fluorescein angiography में there is a tumor blush. Then we do the bone scan, bone marrow biopsy, aspiration, etc., etc. How do you treat Dr. retinoblastoma? Fundamentally, the primary goal, survival, retention of the eyes and vision, avoidance of secondary malignancies, facial bony deformities. So, the treatment modalities, if you look for enucleation, exenteration, surgery, locally, cryotherapy, photocoagulation, laser hyperthermia, radioactive block बिठा सकते हैं. Then radiotherapy. You can do the external beam radiotherapy, radioactive block or particle treatment, systemic chemotherapy, which is administered intra-arterially. 2-3 points about each of them. Enucleation, when will you do it? You will remove the globe after severing the rectus muscle, optic nerve is being cut. Don't forget, at the time of enucleation, do you want to cut a small part of the optic nerve to look for the metastasis? Examiner पूछेगा, आप क्या बोलेगा? क्यों नहीं? मैं optic nerve का 10 to 20 millimeters also I will cut at the time of enucleation. Favorite MCQ. Whenever unilateral RB with a blind eye or a bilateral RB with both eyes blind, bilateral enucleation. Then unilateral bilateral RB glaucoma ho gaya to enucleation. Any local recurrence after conservative management, enucleation. Bilateral retinoblastoma in which you get any of these glaucoma or anything, enucleation. Any tumor going into antechamber and retinoblastoma unresponsive to local therapy, enucleation. Exenteration, इसमें क्या करते? ग्लोब को निकालते, extraocular muscles को, lids को, nerves को, orbital fat को, सब कुछ निकालते. Especially when there is an extensive local tumor which is breaching the globe, you need to do exenteration. Local therapy, where do you use? Suppose the tumor is small, kitna small, less than 3 to 6 millimeters small. Usually with patients with bilateral disease, you, along with chemoradiation, you will use local therapy. So you do cryotherapy when the small tumor anterior to equator 4 to 7 mm, or a small recurrence after radiotherapy, or in conjunction with chemotherapy, you will be doing the cryotherapy, is what you should remember. Then you also do photocoagulation if the tumor is less than 4 to 5 millimeters and 2 to 5 millimeters thick. But if there is already vitreous seeding, that is a contraindication to photocoagulation. By a radioactive ablation, radioactive plaque application karte, what are the radionuclides that you use, doctor? Cobalt 60, iridium 192, I 125, and the RH 106 are the ones which are used. Radioactive plaque. Any solitary lesion 2 to 16 millimeters, unifocal, are located greater than 3 millimeters from the optic nerve or fovea with the thickness less than 10. They are all the indications for doing the radionuclide therapy. External beam radiotherapy, where do you do? If there is a multifocal retinoblastoma, right? Is the broadcast is smooth, doctor? Or is there any slow down of the broadcast? Can you please punch? Is it too flickering? Okay, I'll do one thing, doctor. I will go out of the stream, stop the broadcast and restart. Don't worry, retinoblastoma थोड़ा extensively पढ़ना पड़ता क्योंकि it is a very important topic. Okay, voice is clear, but video problem. Yeah, I stop broadcast and restart. Okay, please stay online. हम लंच को जाने के पहले जरा ये रेटिनोब्लास्टोमा को खत्म करके जाएंगे, राइट? या, इज इट ओके? प्लीज स्टे ऑनलाइन.